Dr. Tanya Popley, who's a first year DNB resident in pediatrics, and she'll be presenting a case of steroid dependent nephrotic syndrome and its associated complications. So, what do you, Dr. Tanya?
Okay, thank you so much, sir. So I'll start my topic, steroid dependent nephrotic syndrome. My patient name is K, aged 4 years 2 months, male, date of birth 29th May 2022, and informant mother. Patient was admitted on 5th of August 2026. Came with complaints, generalized body swelling for 15 days. Child who is a known case of steroid dependent nephrotic syndrome came with complaints of puffiness around the eyes that started 15 days back, and the swelling was gradually progressive, was insidious in onset, and slowly it involved from periorbital region to whole of the face. And in like mother told that the swelling was initially noticeable in the morning and then decreases throughout the day. Also complained of generalized abdominal distension, which developed over last 1 to 2 days. Then mother noticed swelling of bilateral lower limbs, gradually progressed from feet then to ankle to knee, and had diurnal variation. Used to be more during the morning and reduces throughout the day. Also had associated reduced urine output. Mother noticed that it was reduced frequency of urine. There was no associated history of breathing difficulty, palpitations, uneasiness at the chest, gross hematuria, cola colored urine, no yellowish discoloration of urine, reduced oral intake, or clay colored stool. Now, negative history. There was no associated history which was suggestive of cough, cold, fever, the pain associated with redness in any part of body, no history of flank pain, diarrhea, abdominal distension, no history of dysuria or increased urinary frequency, passage of frothy urine, any recent sore throat or skin infection, headache, blurring of vision, vomiting, or no history of any medicine, recent use of medicine like NSAIDs.
So, Dr. Tanya, why did you ask all this negative history in this patient whom you know is already a case of steroid dependent nephrotic syndrome?
So, which history?
All this negative history, specifically like flank pain, what does flank pain suggest?
Sir, I asked about flank pain, abdominal pain because infection can precipitate, like patient can have bacterial peritonitis. So that remains important when patient is already on steroids and is a known case of nephrotic syndrome.
Okay, anything else which can cause flank pain? One.
Ascites, if the patient has ascites, then it can cause.
Ascites will cause generalized abdominal pain, na? Because of
Yes, sir.
stretching.
Yes, sir.
Flank pain is very specific for kidney related pains.
Yes, sir.
So, what kidney related? So, one can be any infection, something like a pyelonephritis.
Yes,
Two,
sir.
it can be a renal vein thrombosis. Because a renal vein thrombosis, your kidney will get enlarged. Okay. So, when it gets enlarged
Yes, sir.
because of the vasogenic edema, so that time you may have flank pains.
Okay, sir. Yes, sir.
Then diarrhea is again for the infection. So every
Yes,
time
sir.
in nephrotics, usually you'll find an infective diarrhea, or do you have any other causes for non-infective diarrhea as well?
Sir, we can have non-infective diarrhea as well.
What is the reason for that?
Sir, so if there is suppose patient is already on steroid and so can have gut related issues. So steroid can cause diarrhea and it can be non-infective in that case scenario.
Steroids directly does not cause diarrhea. What can happen is there's a lot of gut edema. So once you give
Yes, sir.
steroids and the child starts improving, okay, in those circumstances, and since the child is improving, so your gut edema may actually get released via you can say the stools. So because of that, you may have some diarrhea, which may be a non-infective diarrhea per se.
Okay, sir.
Mm.
Then
Then no
past
is
history.
This is come back to them.
Sir.
What do you mean by frothy urine?
So frothy urine, frothy urine will tell if there is protein or if there is any like from urine if there is like excessive protein that is coming out,
But
and
this child
other than
already
that,
had. this child already had proteinuria, na? It came in a state of relapse.
Yes, sir.
So again, you said there is no frothy urine.
So patient, like, I asked this history that it was not visible, but they checked when through dipstick, so it was around 3 plus.
Fine.
So that's
So
why
again,
they.
the point that you have to understand is that it's not mandatory that every time there is protein in the urine and you'll get frothy urine. You may
Yes.
get, you may not get it all. And frothy always does not mean, and if it's the other way around, the child is having frothy urine, but at the same time there is no protein in the urine. Okay, so that can happen.
Mm.
It's a concentrated urine, or you are having crystal urias. Concentrated urine will have a lot of salt deposits, so that can also give
Yes.
rise to some kind of froth. But every time a
Okay,
frothy
sir.
urine is there, most of the time it means that there is protein in the urine, but it's not mandatory. And in the froth also, what you have to remember is persistent froth. Means the child passes urine, it is frothy. Half an hour down the lane, the parent comes and sees the froth. Is froth is still active, it's still there. So
Hmm.
persistent frothy urine is what you call label it as, maybe because of proteins. A transient frothy, it came
Okay,
and
sir.
5 minutes the froth has disappeared. That may be related to other causes as well.
Okay, sir.
Fine. And why did you ask for headache, blurring of vision, vomiting?
Sir, because patient can have any thromboembolic episode, so
Mhm.
which can lead to headache, blurring of vision, vomiting.
Fine. Thromboembolic episode. What else?
Because it's a thromboembolic episode because nephrotic syndrome is a hypercoagulable state, so it can lead to that. And other than that, patient can have associated symptoms like increased intracranial pressure, hypertension, or so it can
Mm.
it will lead us to whether
Hypertension can
patient has
also cause.
hypertension or not.
Yeah. So hypertension can also cause this blurring of vision. Okay.
Hmm.
It's most probably like a hypertension encephalopathy or a press-like scenario.
Yes, sir. So in that case, patient will present with severe headache, vomiting, visual symptoms, and like other symptoms with this.
Right. Good.
Okay. Now, past history. First episode happened on 13th of September 2024. There was no associated hematuria, hypertension. Serum create was 0.3. Patient went into remission in 2 weeks after starting the treatment with prednisolone. Patient received 6 plus 6 weeks of prednisolone therapy. Now this table suggests the like course of relapses. First episode on 13th of September, and after the patient was started on therapy, there was remission. So first relapse happened after 14 days of the starting of therapy and the remission, after 14 days of remission. Then there was second episode while patient was already on prednisolone 1.5 mg per kg on alternate day. So after that, mycophenol MMF started
You mean to
because
say the
after
first
that,
relapse happened when the child was on steroids?
yes, on first relapse, patient was not on steroid. After 14 days completion, patient had, and then on the second episode, patient was already on prednisolone 1.5.
And he got a relapse.
Yes, sir.
Fine. So
Then
such
MMF. Hmm.
what will you call this patient as?
So then I can call this patient as steroid dependent because for steroid dependent, we have the criteria that patient should already be on ongoing prednisolone therapy and on altern on 1.5 mg, that is the alternate therapy that we give. Sorry, alternate therapy that we give. Or so after that, we can tell that patient is steroid dependent.
Mm. So as per definition, steroid dependent nephrotic is if you have two relapses consecutively, that is back to back, while you're on steroids or within 14 days of stoppage of steroids.
Yes, sir.
Fine. So as the first relapse, if you said that it occurred after 14 days, so that is not dependence. But
Yes,
second
sir.
relapse was while the child was on steroid, so this can be a first episode of dependence, but will not label it as steroid dependent at this time.
Yes, sir. And
Also,
the
say this child is.
next relapse that happened where MMF was started, that was also when patient was already on prednisolone. That's why two consecutive there were relapses, and then after that the trial of MMF was started.
Okay, so finally the child was labeled as steroid dependent because you have two back-to-back relapses while you were on steroids. Okay, hence
Hmm.
you labeled the child steroid dependent.
Yes, sir. Then patients after
That you
starting
saw.
MMF, sorry, sir.
Fine, fine.
After starting MMF, patient had 6 relapses, and so on fifth time of relapse, patient's parents were suggested of renal biopsy, but parents denied. So during the sixth relapse, after that, then like further course that I'll tell later on the slides.
In
Now
general,
coming to
if I ask you, do you feel the MMF was working in this child for steroid dependence or no?
sir, MMF, since patient MMF was not working because since after starting MMF, there were still relapses, which shows that MMF was not working.
Okay. And second question is, child still had relapses, but the child did it. You can say from dependence, the child came out or not. The child may be having frequent relapses, but did he come out of dependence or not?
Sir, the relapses reduced and the steroid requirement was reduced, but not completely. It was incomplete. So, because since after MMF also there were relapses, just the duration increased.
Fine. So there was some response to MMF,
Hmm.
but not adequate, is what we'll say.
Yes, sir.
Scenarios. So basically, to see the response, you have to wait for at least 6 months after starting of your second line immunosuppression. You started
Okay.
MMF, but child showed a response in terms of the dependent dose of steroids came down. So you also have to write what was the dependent dose when you label this as steroid dependence. Example, for
Okay,
your
sir.
before starting MMF, maybe you can say that my dependent dose was 1.5 mg per kg alternate day. On that,
Yes, sir.
child used to relapse. And
Hmm.
after starting MMF, you came down to zero point 0.5 mg per kg alternate day. That was your dependent dose. That means
Yes,
there
sir.
is some response. In such scenarios, if there is no, you can say side effects of steroids per se, or the nephrotic syndrome, in such circumstances, we usually say, okay, you can give a trial and you can continue giving your MMF and see whether things improve or not. But on the
Yes, sir.
other side, if there is no response in terms of the dependent dose remains same, then usually we give a weightage period of around 6 months. 6 months also you don't find that the adequately you are not able to taper off the steroids or the dependent dose has not come down, then you think of changing the drug altogether. Okay, and then we label this as child is having a poor response to MMF.
Yes, sir.
Fine, but in case the dependent dose has actually come down, such scenarios where you do not have any complications of nephrotic or steroid, you can say steroid toxicity, in such circumstances, you can think of slightly prolonging the, you can say the MMF dosing and see whether the
Hmm.
response comes or not. Okay, and such in your patient, the
Yes.
dependent dose came down, but there were multiple relapses. The child was unable to get off the steroids, and hence it was decided that let us go on to something else. So something else means some other immunosuppression.
Yes, sir.
Yeah.
Now, antenatal history. The mother is a registered case, and the antenatal history was normal. Like patient did not, mother did not have any significant related finding. There was no associated anomaly scan. There was no abnormality noted during the antenatal period. Birth history, term
Fine.
delivery,
If you go back to your antenatal history, so antenatal and the birth history, is it of any relevance in a child who has nephrotic syndrome now at the age of 3.5, 4 years, or it's just for the sake of asking you asked?
Sir, I asked antenatal and birth history because congenital and genetic causes are relevant in this case. And since renal disease, they influence child's growth and development, and then antenatal infections, drug exposure, they can be related to steroid dependent. So, if antenatal ultrasound was abnormal, if there was polyhydramnios, or if like initially the patient any infection, neonatal infection. So usually antenatal history is not directly contributory, but it helps us to establish whether there was any congenital renal disease or any relevant perinatal insult.
So you can say there are two scenarios what you have to think about. One is if you say congenital nephrotic syndrome.
Yes,
That is
sir.
the reason why you took all the history, that whether the child was big or there was a hydrops like scenario or the placenta size was very big. Okay. More than
Yes, sir.
25% of the child's weight. Okay. So
Yes,
that
sir.
is, but then your nephrotic syndrome would actually start within the first 3 months of life. Max, you can say 6 months to 9 months, it may start off. But it will not start at the age of 3 and 4 years. Okay, so less likely it is a congenital
Yes, sir.
nephrotic syndrome. Second thing is for
Yes,
looking
sir.
at structural defects of the kidney, that is CACUT, because approximately 1 to 5% of the kids may have an associated CACUT, that is associated VUR may be there, reflux nephropathy may be there. Okay, so that again may give you some hints from the birth history, because if the child is having a VUR and there is reflux nephropathy, you may
Hmm.
develop scarred kidney, you may have a secondary focal segmental glomerular sclerosis, and now the child develops nephrotic syndrome. So
Yes,
that's the
sir.
more relevant association per se.
Yes, sir.
Second is any kind of syndromic association. In case in the antenatal part or
Hmm.
maybe the patient has undergone some genetic testings and there was a doubt about some kind of a congenital syndrome which has a predisposition to nephrotic syndrome, a genetic nephrotic syndrome. So there
Yes,
also
sir.
it helps you in picking up. That's why antenatal history and the birth history is important.
Yes, sir. Now, developmental history. For 4-year-old gross motor, patient runs well, climbs stairs using alternate feet. Fine motor copies cross and square. Language speaks sentences 4 to 5 words and knows and uses common words appropriately. Social skill plays cooperatively with other children, engages and follow rules. So development was appropriate for age.
Again,
Immunization
what is the
history.
relevance of developmental history in your case? It's a nephrotic
Sir,
syndrome. So does it have anything to do with developmental part?
Sir, I asked development history because whether child has any developmental delay or regression, because if there is any underlying genetic or any syndromic cause, so sometimes there can be developmental regression as well
So
if
one is to
initially.
look for any associated syndromic scenarios where your
Yes,
CNS may be involved.
yes, sir. Any neurological,
Second, second reason,
sir. So if there is any metabolic cause that is like that is associated,
what metabolic cause?
sir. Usually if patient has any, since patient is on corticosteroid therapy,
So what will
so
happen with
like
corticosteroid therapy?
so in corticosteroid therapy,
And that
patient
too with
can, sorry,
chronic steroid use.
yeah, due to chronic steroid use, there can have developmental delay, growth suppression, growth delay because
One,
of that.
there can be a growth delay, one. And amongst, if you ask about the developmental past, usually the gross motor milestone may be slightly delayed because of the myopathy.
Yes, sir.
Okay. Or because of your recurrent infection, if the child is catching, again, there may be
Okay.
some developmental delay that may be there, but mainly, usually the gross motor is what gets affected.
Yes, sir.
Fine. So, next.
Immunization history. Child is immunized till date as per national immunization schedule. Vaccination chart was not available. Last patient immunized was DPT2 up to 2 years of age, and BCG scar was present.
And you want to add anything to this immunization history because it's a nephrotic syndrome? Anything
Sir,
specific
because
you want
in
to tell?
immunization history, vaccines are very important because,
Mhm.
like, if patient is suppressant, then I need to know what all vaccinations are mandatory to give as per age, like pneumococcal, varicella, hepatitis vaccine. And if live vaccines are generally avoided during significant immunosuppression. So if patient is on like current ongoing prednisolone full dose therapy, then in that usually immunization is done immediately after that, or if already 14 days have been passed, so after that we usually wait for 1 month. So that's why immunization history in general is very important. And most important is pneumococcal vaccine because like it can cause serious infection, peritonitis in nephrotic syndrome children.
Fine. So, basically, there are two, 3 points that you're supposed to add on. General things, what you have written is for a normal child.
Yes,
Okay.
sir.
From nephrotic perspective, one is any mixed vaccinations. Why missed? Because
Hmm.
as you rightly told, live vaccines will be avoided while you're on immunosuppression. that needs to be given 1 month after you stop the immunosuppression, or in case in your child where things are lagging behind and you're not been able to stop your steroids for almost a year, then once you're on the
Yes,
very
sir.
lowest possible dose of steroids, means less than 0.5 mg per kg, you can still give live vaccines. Second thing is,
Yes,
so
sir.
there's a lot of chances that this child would have missed his vaccine. So you need to keep a tab of it. And the moment you're on the lowest possible dose of
Hmm.
steroids, ideally speaking, once you have stopped your steroids, okay, 1 month for your
Hmm.
live vaccine and 15 days for your killed vaccines, you're supposed to give him the catch up vaccines. Otherwise,
Hmm.
since he's already immunocompromised because of the disease as well as because of his immunosuppression medicines, so he will have a tendency to catch infection, and these infection will again precipitate nephrotic syndrome. So better is
Yes,
to
sir.
find out the right, you can set the window and give him the vaccinations whichever are there, and keep a tab of it. Secondly, there are mandatory vaccines for nephrotics. One is a flu vaccine, varicella vaccine, your pneumococcal vaccine,
Yes, sir.
and your meningococcal vaccine. All your coccal vaccines are mandatory. So why is
Yes,
coccal
sir.
vaccine mandatory, whether it's meningo or pneumo? What happens? Why
Uh,
it is specifically that these kids will have a predisposition to catch coccal infections?
so because in nephrotic syndrome, usually IgG and complement they get excreted. So in that case, usually if the IgG complement is low, pneumococcus will have more, like pneumococcus infection will have more tendency to affect the child, and the child will like catch these infections like faster as compared to other children.
Basically, this IgG being low and the child's immunity is low is valid for all your vaccines and all your infections. But meningococcal, pneumococcal, coccal specifically is because you lose propyridine factor B in the urine, and that is required for opsonization of this coccal infections. Okay, so since we have lost this
Okay.
propyridine factor B, so your chances to catch coccal infection is pretty high. So hence it is mandatory that you give them the meningococcal and pneumococcal vaccines. Okay,
Okay, sir.
fine.
Now,
Go.
nutritional history. Patient was taking adequate nutrition as per age. Patient requirement of protein and intake was adequate, and patient calories were also adequate, so no deficit.
Here you're
Now,
supposed to basically see is usually we never get calorie deficit in such children because once you're on steroids, they are basically the appetite gets stimulated and they take a lot of food. But
yes,
what you
sir.
have to mainly see is that they should not get protein deficient. If there is a
Yes, sir.
protein deficiency because of your leakage, anyways, your proteins are going to be low for a lot of time. And on top of that, when you're normal, you're still taking a like there's a protein deficit, then his growth will get compromised. Fine.
Yes, sir.
Just where,
Yes,
like,
sir.
what advice will you give to a parent who says ki my child is having nephrotic regarding protein?
Hmm.
Advice do you give them? You give them a normal protein diet, you give them a high protein diet, you give them a low protein diet. What kind of protein intake will you suggest to a child who has nephrotic?
Sir, I would suggest to take like adequate protein diet, not the appropriate for age, and routinely like high protein diet in nephrotic syndrome is not suggested. Like the adequate, appropriate for age, normal growth, for normal growth is usually advised.
Fine. The basic scenario is do not tell them low protein diet. A normal to high is good enough.
Hmm.
Basically, you have to
Yes, sir.
ensure that his protein intake is adequate, or you can say as per the RDA. Okay.
Hmm.
Then being if patients say I am leaking a lot of proteins, I need more proteins, you just have to explain them that it's a sieve. So you are whatever you're taking is leaking out. So there's no point
Yes.
in a high protein diet. Only
Yes.
exception is steroid resistant nephrotic syndrome because they continue to leak for you can say months together. So since you
Okay.
continue to leak for months together, that is the only exception where we ask you to give high protein diet. Otherwise, it's supposed to be normal protein diet as per the RDA.
Okay, sir.
Fine. So that is what you have to ensure.
Now, socioeconomic. Yes, sir.
Yeah, tell me.
Now, socioeconomic history. Head of family father. Number of family members four. They lived in 1 BHK. Filtered drinking water. Sanitation and hygiene was maintained. There was no cross ventilation. Overcrowding was present. And so they belong to lower middle class as per Kupuswamy scale.
Okay, so now again a question: what is its relevance in nephrotic syndrome? Or
Sir,
you
so
just ask
basically,
them?
socioeconomic history is important in this case because since we are asking patient to take steroids, and steroid reduces the immunity. So if there is overcrowding, then more patients will be susceptible to infections, specifically tuberculosis. And other than that, since patient will require everyday monitoring or like regular monitoring of adequate or urine protein and adequate nutrition for proper growth and continuous hospital visits. So if the socioeconomic status is good, so it makes the compliance easier.
Fine. So it's not makes the compliance easier, but because at times your high socioeconomic status people also may not have a good compliance. But then
Hmm.
lower socioeconomic, the risk of getting infected, especially in an overcrowded state, is on the higher side. So if
Yes.
overcrowding, again, like maybe one sibling has cough cold or some one person has a cough cold, and it's one room which you are sharing, definitely your risk of catching infection increases. Second is, as you have
Yes.
rightly said, there is no smoker at home because again,
Hmm.
smoke can cause allergies. So infection and allergies both trigger nephrotic syndrome. So if
Yes, sir.
scenario where you stay in a, you can say, a house which is on the main road and there is a lot of dust which is there, or you stay
Hmm.
close to a factory where there is a, you can say, a lot of environmental pollution is there. So anything can trigger off a nephrotic syndrome, especially because of the allergy perspective. So you have to see both the allergy as well as the infection angle from the socioeconomic status. And
Yes,
whether
sir.
these patients are, compliance also depends upon whether they are slightly, you can say, literate. Because if he's literate, he can make up,
Hmm.
you can say, the protein diary, everything. He understands what doses you are giving, the relevance
Yes, sir.
of you immunosuppression on a long term basis. Okay,
Yes, sir.
that needs to be seen. Secondly, it is again the compliance from the perspective of costing. So if you belong to a very low socioeconomic status and he
Hmm.
does not get his medicines on a timely manner because of the cost factor, because your
Yes, sir.
second line immunosuppression are usually on the costlier side. So then
Hmm.
compliance may get affected.
Yes, sir.
Fine. So if I go back to your same case where you said MMF did not work well. So
Sorry. Huh. Yes, sir.
just because you were giving and you made the chart and you feel the things are not working well, and you just label this child as okay, it did not work well, let me shift over to some other immunosuppression. So
Hmm.
do you want to check a few things in terms of compliance before you say ki, the patient is not taking, no, no, the response is poor?
Yes, sir. Like adequate dosing, asking the parents whether they were giving the medicines like every day or like with proper timing. So all of these remains important before we label
First
steroid
is the timing
dependent.
of the medicine. Two is whether he's giving an adequate dose or not. You can ask them to get the bottle and you see how much dose. If he has written
Hmm.
2.5 ml, is he actually giving 2.5 ml or not? And again,
Hmm.
it is MMF. So MMF, either it is given in a tablet formulation, which the child has to actually swallow because it's a cold
Yes.
tablet. Okay, at times what happens is he buys the tablet, but he crushes and then gives it. So obviously the efficacy goes down. Two,
Hmm.
MF, if given as a syrup formulation, has to be once you have made it comes as a powder format, and then you have to add water, shake it,
Hmm.
and then you have to store it in a cool place, especially in a fridge. And the, you can say, the duration once made, the shelf life is 2 months. So if the patient is not storing it in the fridge, he is keeping it outside. He is not sticking on to that. He has to finish the bottle within 2 months. He is using it beyond 2 months. Again, you will find the response is poor. At times,
Okay.
you prefer the
Yes, sir.
child takes it empty stomach. Now he may be giving at times with food, with time, sometime without food. So again, your levels in the blood will keep on changing. So all those
Yes.
things need to be checked before you say that the drug is not working. So every drug
Yes,
has
sir.
its own, you can say, the checklist. Okay, if you're giving cyclosporin, how much dose is taking, how is he taking? He's taking with some medicine, he's taking it empty stomach. So all those things need to be checked.
Yes, sir.
Okay, yeah.
Now, summary 4-year-old male who's a known case of nephrotic syndrome since September 2024 came with generalized body swelling, which was insidious in onset, periorbital puffiness, which was more during the morning, and it progressed from periorbital to facial puffiness, then to abdominal distension. Subsequently, bilateral lower limb edema, feet, ankle to knees, and initial episode treated with 6 plus 6 week of prednisolone therapy, and remission was noted.
Again, one
After.
question here was, as you said initially, that child was started on prednisolone. I'm talking about the first episode. So,
Hmm.
in how much time did he attain remission?
Sir, in 2 weeks we check for the remission
No,
for
we
in
check
like
what
14
how much
days.
time did the child get into remission.
Sorry, sir.
Once you started prednisolone for this child for the first episode, in how much
Hmm.
did the child attain remission?
Okay, after starting prednisolone, after 4 to 5 days, the like after, on dipstick test, the urinary protein started to reduce, edema started to reduce. So remission started after 5 to 6 days of starting
Fine.
prednisolone.
First question is, what is remission? It is 3 days of negative or trace on a dipstick. Fine.
Hmm.
Or if you're doing a protein creatinine ratio, it should be less than zero point 0.2 on
Yes.
3 days together. That is remission.
Yes, sir.
It's not the child started improving,
Hmm.
that started decreasing, but 3 days of negative trace should be attained. That is remission. So normally it is said that
Yes, sir.
you attain remission within 2 weeks. So this child is an early responder.
Hmm.
If child responds in 4 to 6 weeks of steroid therapy, he is a late responder. These children will have troubles in terms of becoming either frequent relapser or steroid dependent because he takes a lot of time to get into a state of remission. Fine.
Hmm. Yes, sir.
Within 6 weeks, also, he does not attain remission, then he is labeled as steroid resistant. Hence, it is very important in your case presentation that you tell simultaneously when you're talking about the first episode that average once you start a full dose steroid, that is 2 mg per kg,
Hmm.
time does it take to attain remission? So that tells you his steroid
Okay.
sensitiveness and early remission versus, well, you can say early responder versus late responder. Fine.
Yes, sir.
So that has a
Yes, sir.
prognostic implication in his long term perspective.
Yes, sir.
As you said, it's a 4-year-old male, and 2 years back, at the age of 2 years, he had nephrotic syndrome onset. So, does it have
Hmm.
a clinical correlation on the long term? Or a child who comes less than 1 year, means example, I'll give you like 3 months of age and nephrotic, 10 months of age and nephrotic, 2 years of age and nephrotic, and maybe 10 years of age and a nephrotic onset. So, is that the variation in the natural history?
Okay, so depending on the age, if the patient is so if the early stage onset, there will be poor
Early stage,
prognosis,
you tell me
and
that age and you tell me the outcomes. So if we talk
so
about
if the th-
something like a
hmm,
congenital nephrotic syndrome, he develops his nephrotic state within three
at three
months of age.
months,
Now,
yes, sir.
what is this natural course and prognosis?
So if at 3 months of age, so it will most likely be congenital nephrotic syndrome, genetic cause. So the prognosis will be poor, and if the patient is usually around 10 months, that's called infantile.
Again, from the
So,
nephrotic
but
perspective, if it's a
hmm,
congenital nephrotic syndrome and you have a genetic cause, fine.
yes, sir.
So your chances of attaining remission is negligible. And by the age of say 6 months to max 2 years, the child will end into a end stage renal disease requiring
Hmm,
dialysis and finally a transplant. But on
yes,
the
sir.
contrary, it's a congenital nephrotic syndrome triggered off with some infection like a CMV. So there is a high chance, and genetics are negative. Then there is a chance that once you treat the infection, the child may attain remission. Okay.
Yes, yes, sir.
Next is a infantile nephrotic syndrome. 9 months, 10 months of age, and now he
Yes,
develops
sir.
nephrotic.
Hmm. So in infantile, so like during this, the response to steroid is very unpredictable. So after giving the steroid therapy, you can only decide whether the patient is going to respond well or not.
Fine. So if it is a infantile nephrotic syndrome, means 9, 10 months of age, you started steroids like a normal nephrotic treatment, and the child is an early responder. So his
Hmm.
prognosis is equivalent to a child who comes at 2, 3 years of age and develops nephrotic. But on
Yes,
the
sir.
contrary side, he does not respond. He becomes a steroid resistant, and your genetic test turns out to be positive. So he starts behaving again like a
Hmm.
congenital nephrotic syndrome. Okay. Now, a 2 years old
Okay.
child, like this child who develops nephrotic versus a 10, 11-year-old child who develops nephrotic. What is the difference in the two? Prognosis.
So during like around 2 years of age, the response to steroid is usually good, and but in later stage, so the relapse can happen more. Like there are more chances of getting relapse or like this response to steroid is also again gets unpredictable if around preschool patient presents like
Again, it
that
is not
later in stage.
unpredictable. That is not the word to be used. Again, in general, what you can say, if the child is a responder, if the child is non-responder, everybody
Hmm.
falls into the same category as steroid resistant. But if the child is a responder,
Yes, sir.
so in those circumstances,
Huh.
we are specifically in this child. So who is a responder,
Hmm.
an early responder. So usually the younger you are, the more the number of relapses you have. And why is it so? Because you have a tendency to catch more infections, either because of your low immune profile, because of the age, as well as your, you can say their friends group who also belong to the same age group. And again, they have a lot of infections, especially the virals or the URIs, and they keep catching it more often. But if it's
Hmm.
a 10 to 11-year-old child who is responding to steroid and he starts wearing a mask, his basic immune profile is better. His, you can say the environment also is the same age group, people also catch less infection, so his relapses are also much lesser comparatively. Okay, the older the
Okay.
age group and you're a steroid responder, outcomes are better
Okay.
unless you come beyond 12 years of age where you have a big chance of having non-minimal change kind of a disease like a
Hmm.
you can say IgA nephropathy kind of scenario presenting like a nephrotic, or you can say FSGS coming like a nephrotic. So there everything boils down to whether you are a minimal change disease child, you respond beautifully to steroids or not. That determines the prognosis.
Okay, sir. So diagnosis is steroid dependent nephrotic syndrome based on our history.
With
Now general
steroids. Web, sorry, MMF.
sorry,
I said with poor response to
with poor
MMF.
response to MMF. Yes,
So
sir.
before we go ahead, there's a two question that have been asked. What vaccination should be done if the patient has received rituximab? So you want to answer that?
Sir, if the patient has received rituximab, in that case, the vaccinations we can usually give um, only the vaccines that. So yeah, I did read about this. Only the
So
vaccines that
normally
have
again, the vaccination does not
B
change.
cells and reduce antibody response. So pneumococcal vaccines can be given.
Again, remember your types of vaccination does not change. All the same nephrotic syndrome vaccines you'll have to give. Only
Hmm.
thing is regarding rituximab, which you have to be clear is meningococcal vaccine is mandatory because
Hmm.
rituximab children have a high predisposition to catch meningococcal infections. Two is when do we actually go in for vaccination post rituximab?
So we
So
wait
ideally it
for
is said.
around. Huh.
Yeah, tell me.
Sir, so after rituximab completion of therapy,
So what is
we wait
completion
for some
therapy?
time, like around. Sorry, sir.
How much time do you wait before giving a vaccine after giving rituximab?
Around 6 months.
Fine. So normally what you are supposed to answer in the exam is once the B cell population has recopulated, means normally rituximab is anti-CD20. Okay. So
Hmm.
your B
Yes,
cell
sir.
lineage will become low. Our target is to keep it below 1% CD1920 cells. Okay. So once it has
Hmm.
recopulated, it has come back to its normalcy phase. So if you have given 2 doses of rituximab, average recopulation time is 6 to 9 months. So once you are back
Yes,
to
sir.
your immune profile, 6 to 9 months have passed on. Now is the time when you can give him the vaccination. Okay.
Yes,
Next
sir.
question was role of probiotics to prevent relapse. Is there any literature which says probiotics prevent relapses?
Sir, I'm not sure about this, but
Fine. There is no
I can.
literature on probiotic preventing relapses, but in case
Hmm.
you have a diarrhea and you want to give probiotics, that's more than enough. That is for that perspective. Okay, since you have treated the diarrhea, so diarrhea becomes better, the relapse also will get better. But there is nothing called as use of probiotics for preventing a relapse. Okay.
Hmm.
Yeah.
Okay, sir. For general examination, head to toe, patient had cold, clammy skin, normal distribution of hair, periorbital puffiness present, facial puffiness present, and significantly abdominal was distended, limb swelling present on both the limbs. There
Fine. So
was
you
no.
can now onwards you can like in the examination just stick on to what was positive. So in
Yes,
your
sir.
general physical examination, you're told there is cold, clammy skin. Okay.
Hmm.
And your abdomen was distended, maybe because of your what is ascites.
Ascites. Yes, sir.
Fine. So there is a generalized anasarca which is there. So you
Yes,
can
sir.
overall edematous, and there is cold clammy skin. So, what does cold clammy skin suggest in a child who's edematous, nephrotic, in a state of relapse?
Sir, there will be poor peripheral perfusion. There will be, because of this, patient will have dehydration. So, cold clammy skin will suggest patient has dehydration and hypovolemia can occur, poor peripheral perfusion. So, this can be the reason for that.
So, in such patient, think twice before you initiate your diuretics, because if
Yes,
the
sir.
third spacing has occurred and intravascular volume depleted, that's why the child was cold clammy. So, always
Hmm.
supposed to give him albumin first,
Hmm.
assess his intravascular status, and then only give, you can say, a diuretic. If you
Yes.
directly go into jumping into a
Yes, so first we give.
diuretic, the child will develop pre-renal
Hmm.
AKI. Okay, and you may not get an
Yes,
adequate
sir.
response of your diuretics. Second can be if the
Yes, sir.
child is presenting in a state of sepsis. So, just as a part of,
Hmm.
you can say, a starting of septic shock, the child may develop cold, clammy skin. So, if a child comes with spontaneous bacterial peritonitis like phase, okay, and clinically looks
Yes.
like an SBP, and abdomen is tender, it is red, inflamed, okay, and has cold, clammy skin, so this child may be entering into a state of septic shock.
Yes,
Yeah.
sir.
Next.
Now vitals. Pulsar patient had tachycardia, and their capillary refill time was delayed around 5 seconds.
So again,
BP
telling
was.
you that since you see the BPs are not that bad, okay.
Hmm.
So BP not that bad, but child is having tachycardia, CFT is delayed, cold clammy.
Yes, sir.
This thing, it's a dehydration like phase.
Dehydration,
If the
like yes, sir.
BP also
Hypo.
falls down, then it's like a state of shock.
Yes, sir. So
Yeah.
that's when
So
hypoalbuminemia
it's
we
like a
can have.
pre-shock like stage, but where
Huh.
you have to act early. So if such a patient comes to your OPD, always advise them for admission.
Yes, sir.
Yeah.
Anthropometry. Weight 17.3, height 102. Patient was adequately nourished, and weight was around 25th to 50th centile, and height was around 50th to
So
25th.
normally, if a steroid dependent nephrotic comes to your general, like you have seen so many steroid dependent nephrotic syndromes. So
Hmm.
usually, what kind of anthropometric measurements do you get in such children? Not in this side, in general. As SDNS, like a patient who is chronically on steroid therapy, maybe for 1 year he has not stopped his steroids. Okay.
Mm-hmm.
So what kind of anthropometric measurement do you suspect that most of the patient will be having such anthropometric measurements?
The weight will be more
Yeah,
because of
weight will be
steroids,
more.
and
Yeah.
since due to excessive steroid use, and because of excessive steroid use, there can be stunting of height. Like height can be, like due to short stature can be there, growth
Fine. So
retardation can be
basically,
there.
your the usually what we find is the BMIs will be on the higher side. A
Huh.
short-heighted kid who is obese is what you find
Yes.
because in a
Yes.
child with steroid dependent most of the times. In this
Hmm.
side, everything was fine. And
Hmm.
again, remember, try to plot a chart rather than taking absolute values. Because what
Okay,
may
sir.
happen is like if you say height is looks normal, 50th to 90th centile, but maybe a child is there who initially had a height of 95th centile and now slowly has gone down to
Hmm.
25th centile. So if you just see him spot as of now, you may find 25 centile is good, but a child who's losing
Hmm.
height in terms of percentiles is a,
Hmm.
you can say a side, or you can say side effect of your nephrotic state as well as your steroids. So that
Yes.
again is an indication to start second line immunosuppression in case the child is not on second line.
Okay, sir.
The child has started developing complications of nephrotic syndrome or the drugs.
Okay, sir.
Hmm. And
Now,
second thing, the higher the BMI and more obese you are, the more
hmm.
chances this child will have features suggestive of hypertension.
Hypertension. Yes, sir. Now, systemic examination on gastrointestinal inspection, abdomen was distended. Then, on palpation, there was no abdominal tenderness tria. Like on percussion, shifting dullness was present. Respiratory
And again,
system
in the
and
exam,
cardio.
just go back to abdomen.
Hmm.
Abdomen. So, okay, so again, remember you're supposed to see the inspection mainly to look for the
Stria.
features of spontaneous bacterial peritonitis.
Yes, sir.
Two, for looking features of ascites versus a Cushingoid pot belly kind of scenario.
Yes.
So if your umbilicus, always comment on umbilicus. If your umbilicus is stretched, that means there is ascites. If the umbilicus, like
Ascites.
smiling umbilicus, if the umbilicus looks normal, it can be because of the Cushingoid nature.
Yes,
Things
sir.
which are not fitting in is at one time you write umbilicus stretched. That means there is a, you can say, a grade 3 or a 4 ascites, but at the
Hmm.
same time you just written a shifting dullness present. So grade
Hmm.
3 or ascites will be like full. There may be a horseshoe shaped dullness, or there may be, you can say, you can say grade 4 ascites. But shifting dullness present is
Shifting the.
suggestive of a grade 1 ascites. So that
Yes,
does
sir.
not match. Okay, so you're supposed to look
Hmm.
for
Okay, sir.
ascites, features of SBP, features like you can say stria, distended abdominal vessels, and never forget to talk about genitals in your abdominal examination, because this child may
Hmm.
be having penile edema, may be having a scrotal edema. The scrotus may be
Hmm.
tender if there is some infection, so you're supposed to comment on that as well.
Yes, sir. There
So
was no
next,
scrotal edema or
fine,
redness. And on palpation, there was no abdominal tenderness, no
fine, fine.
local
So
rise of
come
temperature.
to the next one.
The respiratory system was normal on
Fine.
inspection.
So respiratory, what you're supposed to look, features of any respiratory infections, like creps, maybe, or wheezing, from allergy perspective as
Yes,
well as
sir.
from infection perspective. Two, if there is pleural effusion,
Yes,
then
sir.
again you'll have features like we can say of this thing, pleural
Crepitations,
effusion.
basal crepes will be
Okay.
there.
Basal Krebs is usually for your pulmonary edema if there is
Yes, sir.
hypertension, but you'll have a, you can say, decreased air entry at the basis. That is because of your pleural effusion. So that is
Hmm.
what you are supposed to check. Next,
Yes.
coming to cardiac, specifically
Cardio.
check something.
Sir,
Again,
will
you can
evaluate.
have a pericarditis.
Hypertension can be there. So after that, heart rate, tachycardia will be there.
So
And other,
tachycardia will be there. Then
so tachycardia was there, but like patient did not have any raised JVP or heart sounds were normal. So that suggests there
fine.
was
So,
ascites, but there was no volume overload. So patient did not have any heart failure features.
fine. So features of heart failure, which is congestive in nature. Two,
Hmm.
again, you can have pericardial effusion. So your heart sounds may be muffled.
Hmm.
If there is a chronic hypertension, either because of disease or because of the drugs, then again you may have, you can say, features of left ventricular hypertrophy.
Yes, sir.
Okay. CNS, what you're supposed to check in such patients?
So sensorium is important in CNS.
Fine.
And because if there is hypertension related encephalopathy or raised intracranial pressure, so for that I'll check sensorium, any headache or neurological deficit I'll check, or like I'll also check for visual symptoms. If there is any, due to raised ICP, there can be like pupil can be non-reactive. So to rule out hypertension and any severe infection that causes meningitis, so
So
headache.
CNS pictures, what all you can expect is one, like features of related to hypertension. You can have hypertensive encephalopathy.
Hmm.
Two, with this you can have raised ICPs where there'll be bradycardia with hypertension. Three, this child has a high chance of thromboembolic episodes or cortical venous
Yes, sir.
thrombosis, so features related to that. And lastly, meningitis
Hmm.
infection. So that's why in this thing you'll have to talk specifically, even if it is normal, but you can say no feature suggestive of XYZ things, so that the
Hmm.
examiner should know that yes, you know what you are supposed to check in a child with nephrotic syndrome.
Yes, sir.
Fine. Next.
Now investigations. So for investigations and CBC, then patient's urine routine was done. CBC was normal, which shows there was no increase in TLC count, so no infection. Then urine
Again,
routine.
PLC counts can rise because of infection and it can rise because of a steroid therapy also.
Yes, sir.
Such a child who
Yes, sir.
was, you can say, third spacing was there, cold clammy skin, may sometime you may get hemo concentration. Your HB may actually rise. So if you write HB is
Hmm.
10, maybe his actual HB may be 8. And that's why, because of the hemo concentrated state, is appearing like a 10. Platelets are
Okay.
very high, it's not normal. So this is
Yes, sir.
thrombocytosis.
Yes, sir.
Again, it can occur because of infection, stress response, or a chronically, you can say, steroid therapy, and at
Yes,
time
sir.
because of your this as a part of your so infections, chronic steroid
Yes,
therapy,
sir.
stress response, and hemoconcentration. So
Yes.
normally when you give them fluids
So
and
CBC is important for
you
them.
may find that the HB counts, platelets, everything starts dropping. But a high platelet count predisposes the child for a stroke, okay, cortical venous
Hmm.
thrombosis, or a deep vein thrombosis. So such children, if there is
Yes,
persistence
sir.
on the higher side more than 7 lakhs, in spite of giving all the fluids, such children warrant antiplatelet therapy like a low dose ecosprin till the time it does not come back to
Okay.
normalcy.
Okay, sir. Now urine routine, protein albumin was rise. There was 3 plus 500 mg per dl. Other than then, pH was 6. Specific gravity was also high, 1.037. And there were no blood acetone or glucose in urine. First cells were 21. And other than that, the urine routine was fine.
So again, remember, at times you may get glucose in the urine. If it is persistent glycosuria,
Hmm.
that can occur because of any underlying kidney damage.
Yes, sir.
Two, because of chronic steroid usage. There may be
Hmm.
hyperglycemia in these patients. Three, again, as I told you, that if there's a kidney damage per se, damage in the sense like an FSGS where your some of the glomeruli are sclerosed, you can have an isolated renal glycosuria where your sugars are normal, but urine will show sugar. At times,
Hmm.
some children, especially if you're steroid resistant, some children will be given SGLT2 inhibitors, like
Yes, sir.
dapagliflozin. So that
Yes,
also
sir.
will cause some amount of glycosuria.
Hmm.
Okay. And in case the child is having high sugar intake, so that also will cause, you can say, a temporary glycosuria.
Temporary glycosuria.
Yeah.
Yes, sir.
Next, as you have written, pus cells or 21. So does it mean there's a UTI?
Sir, but since pus cells were 21, but leukocytes were negative, so like that is pyuria, but but it does not alone proves the infection.
Fine. So in case,
So for that, it's
again, when
better
your
to go
child is
for
in a
culture
state of
and sensitivity.
so child in a state of relapse, you can have pyuria. Every
Hmm.
pyuria is not UTI.
Yes,
Okay.
sir.
So in case the child has urinary symptom, then go ahead and do a culture. But just by the mere presence of WBC with no urinary symptoms per se,
Hmm.
need
Yes,
not
sir.
do cultures for all children who have pyuria, especially when
Yes,
you have a state of relapse.
yes, sir. For RFT, albumin was 2.58, which was low. And other than that, B1 was 5.16, creat was 0.17, and patient total protein was 4.6. So since patient had cold, clammy feet, and along with that, albumin was 2.58, which shows that patient has hypoalbuminemia towards dehydration. So that's why since patient came, we gave patient albumin and did not directly give diuretics. So first albumin was given, and after even the labs showed that there was hypoalbuminemia.
Again, as a mark of caution, at times you may have hyponatremia in such patients. So either it may be a dilutional hyponatremia because there's a lot of fluid in there, and it's
Hmm.
called dilutional hyponatremia. So such children again think of giving diuretics like a, you can say, Vaptans, tolvaptan, which will just remove the free water. Because if you give a diuretic like a furosemide, it will also cause natriuresis and your albumin, your sodium may actually fall off. So how do you check that? If the serum sodium is low, check for the serum osmolality. If the
Oh,
osmolality is on the lower side, then the ideal diuretic of choice will be tolvaptan. Okay.
yes, sir.
On the other side, if it is actually a hyponatremia where the osmolality is normal, because the parents will be giving less sodium to this child, because some
Hmm.
parents totally restrict the sodium in the child, because doctor would have told no extra added salts and they will be giving no salt at all. Okay. So in those circumstances, you're supposed to supplement them with sodium, either in terms of fluids or in terms of dietary sodium.
Okay,
But then if it is dilutional, you're
okay, sir.
supposed to remove that extra fluid.
Okay, sir.
Fine.
Then biopsy was done. So in biopsy, the biopsy report showed minimal change nephropathy.
Fine. So minimal, all the glomeruli was normal, everything was normal, and your immunofluorescence showed IgM 1 plus positive. Okay.
Yes.
And so 1 plus positive is not significant. Sometimes you may get an IgM 2 plus 3 plus positive. So that
Hmm.
in most of the time it's called as minimal change nephropathy. But in some literature, it is also called as IgM nephropathy. Since there was an IgM
Okay.
deposit, that's why his response to steroids was not that great. He continued to be in a state of dependence. Okay, but mostly
Yes, sir.
IgM 1 plus is like a minimal change disease.
Yes, sir.
Yeah. So we had also sent a electron microscopy whose report usually comes late. And
Hmm.
usually, what kind of finding will you get in such state in an electron microscopy?
So, in electron for minimal change disease, so usually in electron microscopy, we find diffuse and effacement or podocyte foot process are flattened. So, like no significant, very dense immune deposit, but there is flattening
So you will not
of
get
foot
immune,
process
but there will
which
be diffuse
happens.
photocytopathy.
Hmm.
Fine. Next.
So current treatment, patient is on prednisolone 2 mg per kg per day, and MMF was going at 1000 mg per meter square per day. The normal range is around 600 to 1200. So according to patient weight and height, body surface area is 0.69 meters square. So if we calculate, we were giving patient 350 mg twice a day.
So remember, it was not 350, it's 360 mg twice a day.
Okay.
So MMF is available as two types. One is MMF and other is MMF sodium. So normally all your dose calculation is as per normal MMF. So if it is 500 mg BD, what you have calculated for MMF in terms of tablet formulation. Okay, so if
Hmm.
you shift over to MMS, that is micromorphital sodium, then it
Hmm.
becomes equivalent to is 360 mg BD. So that you have to remember. So your
Okay, sir.
calculation is as per your normal MMF. But in
Hmm.
case you want to give the sodium salt of MMF, then that 500 is equivalent to 360 of MMS, and 250 is equal to your uh, this thing approximately say around 180 ml, 180 mg of
Okay,
MMS.
sir.
So what is the advantage
Okay,
of
sir.
microfilament
Yes, so
sodium
one.
over your normal MMF?
So with sodium.
So what is the advantage of MMS versus MMF? Or is just your choice? You want to start MF versus MS?
Sir, if we'll give sodium with this, so there will be lesser adverse effect of MMF, or there will be lesser
So what
GI side
specifically?
effects.
Yeah. So MMS sodium has lesser
Hmm.
GI side effects as compared
Hmm.
to MMF. But
Yes, sir.
you can start either. But in case the child develops GI side effects in terms of you can say loose stools or unable to tolerate your micro and moftail, in that circumstances you
Hmm.
can go to MMS. So earlier the cost of MMS used to be very high, but now it's almost comparable. So as of today, some people start only with MMS and some people start with MMF, and if there's GI toxicity, you shift over to MMS.
Okay, sir.
Okay. And again, before we say that MMF is not working, you
Hmm.
increase the dose to 1200 milligram per meter square per day rather than 1000. If it is not
Okay.
working. Normally, it is said that you always start with 800 to 1200. That 600 to 800 dose is actually when you're tapering or you're going to a lower dose. Otherwise, ideal
Hmm.
dose is 800 to 1200 milligram per meter square per day.
Okay.
Yeah.
Now, clinical summary. So, based on the entire history plus examination, 4-year, 2-month-old male who is a known case of nephrotic syndrome since September 2024, presented with generalized body swelling for 15 days, more in morning and reduces throughout the day. Initial episode responded with 6 plus 6 week prednisolone, and subsequently steroid dependence was developed. Multiple relapses were seen, and on second relapse, while on prednisolone, 1.5 mg per kg alternate day. So MMF was initiated on 20th of February 2025, which was followed by 6 relapses. And in that, we gave adequate doses of prednisolone. Examination revealed periorbital and facial puffiness, bilateral limb edema and ascites with tachycardia and delayed CRT. There were no respiratory, neurological, or cardiovascular abnormality. Investigation showed proteinuria, albumin 2.58, hypoalbuminemia. Total protein was 4.26 and creatine was 0.17. Overall, recurrent relapsing steroid dependent nephrotic syndrome with on current relapse and on MMF therapy
So as per the current
and
biopsy
repeated
report,
steroid requirement.
what drug will you like to choose next? MMF not working. Child is a 4 year old. Which will be the next drug which you'll choose?
Sir, so usually on dependent cases after MMF, we go on CNIs, calcineurin inhibitors, like
Fine. So what
cyclosporin
option do
or
you have?
tacrolimus.
Cyclosporin and tacrolimus.
Yes, sir.
So how do you choose? Cyclosporin you want to give or you want to give tacrolimus? Or both are same?
No, sir, both are not same.
Hmm.
Sir, so basically, cyclosporin and cyclosporin has more side effects.
What kind of side
So
effect?
we look for LFTs and we look for we do a workup on patient,
Hmm.
and based on that we decide whether we are going to
See,
give
the LFT, your transaminitis, your creatinine going high, your hypertension is all common to both the CNIs. Okay. So, what is specific side effect for cyclosporin?
Sir, if there is a boy or if suppose if there is a girl, so usually cyclosporin can cause hirsutism,
Fine.
and it can cause like features of PCOS. So it's better in that case sometimes to give
So again,
tacrolimus.
PCOS is not at this age. So mainly it is cosmetic side effects like hirsutism and gingival hypertrophy. It is specific for
Yes, sir.
calcineurin inhibitor like cyclosporin. Again,
Cyclosporin.
nowadays we don't say boy and a girl, you just say hirsutism. Okay.
Hirsutism.
But even
Yes,
a
sir.
boy at 4 years, if he's full of hair, then it's not easy. If it's a, on the contrary, he's like a 12 or 13 year or a 14, 15-year old who is shaving, so then it does not matter. But
Hmm.
otherwise, hirsutism is common to both.
Hmm.
For tacrolimus, what is the specific side effect?
So tacrolimus is it's nephrotoxic and neurotoxic. It's more
Specific.
neurotoxic. Both are nephrotoxic, but tacrolimus is more neurotoxic and it can also cause hyperglycemia.
So tacrolimus can cause hyperglycemia. Two, it can cause
And it
more
can cause
neurotoxicity.
seizures.
Neurotoxicity and neurotoxic means if the child is already prone to seizures, we prefer cyclosporin. Okay?
Hmm.
And again, it can cause this thing tremors. Okay, and
Yes, sir.
hyperglycemia. So already child is
Yes.
having glycosuria, is already a known case of seizures, or he has developed seizures because of cortical venous thrombosis. I will prefer cyclosporin rather than tacrolimus. Okay,
Yes,
that
sir.
is how you choose. Other thing,
Hmm.
how do you choose? In such child, I'll give you a small example. It's a 4 year old child, and
Hmm.
we gave all the you can say the differences between cyclosporin and tacrolimus, but eventually cyclosporin was started in this child. So this is a hint.
Okay.
So why was cyclosporin started in this child?
So maybe the patient was already on anti-seizure medicine and were already had
And with that, you have
epilepsy
taken the history
syndrome.
by epilepsy. Because
So,
cyclosporin also comes in a syrup formulation. So if the and
okay.
tacrolimus comes only as capsules. So if your child
Okay.
can gulp down a capsule with a sip of water, then tac is better. But if the
Hmm.
child needs a syrup formulation, he cannot take a capsule, then you don't have any option. You're supposed to give him cyclosporin only. Fine. So that is what
Okay, sir.
you're supposed to know. Yeah.
Okay, sir.
So now we'll just take a few questions. So it says repeat the rituximab point and what counts are supposed to. So normally rituximab is a anti CD20. So normally we do a CD19 and CD20 once we are given 2 doses of rituximab 72 hours after giving the second dose of rituximab, and the value it should be target should be less than 1%. So
Hmm.
this lasts for 6 to 9 months, and 6 to 9 months the UK CD19-20 will come back to its normalcy phase. That means the rituximab effect has faded off. So that is the time when you actually give them the
Okay.
vaccination. Then second question was how do you explain anemia in nephrotic syndrome child? So anemia in nephrotic syndrome, you want to tell something? How
Yes, sir.
nephrotic syndrome child get anemia?
Yes, sir. So like in nephrotic syndrome, anemia, it is not a very typical feature, but in steroid sensitive nephrotic syndrome, but there can be iron deficiency due to poor dietary intake
Yeah,
or due to
second
chronic hmm,
second is gut edema.
in
So if there is
gut
a lot of
edema.
gut edema, absorption of iron becomes poor. So
Yes,
that's
sir.
why you get, and specifically it's not just about iron. Your iron, B12, folic acid, everything goes on the lesser side because of the absorption. That may cause your, and even the zinc. So if the absorption is poor, or then you can get anemia. Two, if the child has had some kind of bleeding because of you can say, then you can get this anemia. Thirdly,
Hmm.
the child is having a something like an FSGS like state. So you can say a lot of glomerular sclerose. So that's like a
Yes,
chronic
sir.
kidney disease like state. And because of that, because of the chronic kidney disease like state, this child will have anemia. And then
Hmm.
lastly, if the child is having lots of infections, and that is only triggering the relapses. So
Yes.
recurrent infections can also cause anemia. But normally, most of the time we see
Yes, sir.
that the child is hemoconcentrated in most of the settings rather than anemic.
Hmm.
Next
And
question
other.
is, if the
Hmm.
patient is on tacrolimus, blood sugar is normal, urine sugar 2 plus. So this can be isolated renal glycosuria. But tacrolimus does not cause only renal glycosuria. It increases the blood sugar levels and then only you will get a glycosuria. Unless your tacrolimus has actually caused tubular injury. If that is tubular injury caused by cyclosporin or tacrolimus, then you can have an isolated glycosuria with normal blood sugar levels. Last question is why levamisole is not chosen in this case in place of MMF. So again, it depends upon the doctor who was treating. In case the child is he has an option of choosing MMF versus levamisole, but levamisole is good for children who have frequent relapsing nephrotic syndromes. So if there's a
Hmm.
gap of steroids in between, definitely levamisole I may prefer first. But on the contrary, if he's already a steroid dependent nephrotic syndrome, who's
Hmm.
dependent, and that is the reason why I want to initiate his second line immunosuppression, my choice will be again MMF, not levamisole.
Yes,
So
sir.
levamisole is good for children with frequent relapsing nephrosis. Steroid dependent it may be used but does not have that much of efficacy. The efficacy is just around 30 to 40% in dependent patients. On the other hand, your MMF is almost 60%.
Yes, sir.
And is Dr. Shubham there?
Yes, sir. I'm there, sir.
Fine. So Dr. Shubham is our second year FNB fellow. So what Dr. Tanya has discussed is all related to the nephrotic syndrome. As we know that the Indian guideline, the latest one had come way back in 2021. And recently we have a KDGO guideline in nephrotic syndrome, which came up this year only. So do you want to highlight just three, 4 points? What is different in the current KDGO guidelines versus what the Indian guidelines were? Just you can
Yes, sir.
tell me a couple of points. That's it. And then we close down.
Yes, sir. So, uh, I would like to highlight some key differences between both the guidelines, that is ISPN and KDIGO. So, as we uh, as we can see in ISPN, the exact definition of nephrotic syndrome is a nephrotic range proteinuria with hypoalbuminemia with edema. But in Kidigo, they had said a nephrotic syndrome definition is a nephrotic range proteinuria and either hypoalbuminemia or edema. So they had given or between edema and hypoalbuminemia. So this is the first difference, and
And the
the
reason and
second.
the reason for that is because normally you start leaking proteins first, nephrotic range proteinuria, then your serum albumin comes down, and then edema comes in. So at times you may pick up hypoanemia with a nephrotic range proteinuria. So you don't want the edema to come up, and then you want to start treatment. That's why and has become or. And if the patient has already developed edema, most of the time it means that albumin levels are low, less than 2.5. So that's why or has come in instead of and. Next, second point.
A second point is in the treatment of a nephrotic syndrome. Initially, ISP had given 12 weeks of oral steroids, 6 weeks alternate day. But on the other hand, Kidgo has said 8 or 12 weeks. So Kidgo has given a flexibility in the treatment. Either you can give for 8 weeks or 12 weeks.
So 8 weeks, you mean 4 plus 4?
Yes, sir.
Fine. So that is specifically in case you want to go for the people who are uh, participating. So in case you decide I want to go for 4+4, remember try 4+4 for children who are early responders. Means in a span of say around about 2 weeks, the child went into remission. So there I can give a trial of 4+4 weeks. But a child who goes into remission by around about 3.5 weeks, there it is preferable you give 6 weeks. You don't go for 4 weeks. Because just now he has attained remission and you have dropped the dose. There is a very high chance this child will enter into a state of relapse. Next.
Yes, sir. A third point is in steroid sensitive nephrotic syndrome, if suppose the patient is there, uh, FRNS with a steroid without a steroid toxicity. So in that case, either you can put patient on second line immunosuppressive, or you can continue alternate day low dose steroid. For that, ISP and Aspin said dose would be zero point 0.5 to zero point 0.7 mg per kg, but Kidgo had clearly mentioned it should be less than zero point 0.5 mg per kg per dose.
Reason being, the lower the dose, the lesser is your going to be side effect because you're planning to give a low dose for long time. So if
Yes,
your
sir.
value is more than 0.5 mg per kg, there is a very high chance this child may develop features of steroid toxicity. So the very aim of not starting second line immunosuppression, start going for low dose steroid therapy is to prevent either the number of relapses or to prevent the complications of either the disease or the drugs. So if you continue giving at a higher dose steroids for a long time, so you're the very own reason why you prefer to switch to second line or give low dose is lost.
Yes, sir. Fourth point is in the infection associated relapse prevention. ISPN said you should give a daily prednisolone for 5 to 7 days during fever if a patient is on a long-term alternate day steroid. But Kidgo has said do not routinely give daily steroid during infection. You can consider only 3 doses in a selected the patient who are on alternate steroid therapy.
So this is something new because most of the centers follow that you give low dose. Well, you can just make alternate day as daily and continue it for a long time, maybe for a week, 2 weeks, and then switch to alternate day again. But the current concept that this does not help you to prevent relapses. Okay, since it's not helping you to prevent relapses, there's no point continuing your low dose alternate day, making it daily and taking it for a long time. It's also called a stress dose response. So if there is a stressor, some kind of major infection is there, so 3 days you can make it daily, but subsequently try to shift back to alternate day. And if the child does not develop, doesn't go into remission, then you're supposed to increase the dose.
Yes. And the last main point in the definition of steroid resistant nephrotic syndrome, ISPN uses 6 weeks a cutoff to tell if the patient is SRNS or not. But in the KidCo had mentioned they had given 4 weeks of cutoff, and from 4 to 6 weeks, they had kept that 2 weeks as a confirmation period. In that period, they see if patient responds or not. If patient responds, so they label at a late responder. Otherwise, SRNS.
Fine. So this extra leverage of 2 weeks, which was been given, is basically in case my child the first time he comes with nephrotic syndrome, maybe he has pneumonia. So for pneumonia itself, till the time it does not get treated, your steroids may not work that well. Okay, so since there was a maybe around a 1 week, 2 weeks of infection, so in those circumstances, you can just prolong up to 6 weeks. Two, it's worth prolonging if the child goes into a state of like a partial remission. Means the proteinuria was 4+, now it has gone into 1 and 2+. The serum albumin has become normal. Edema has started settling down. So these patients are worth waiting for 6 weeks. But in case at 4 weeks also you are 4+ and you require, you can say the steroids on the higher dose, and the child is not responding, requires multiple hospital admissions, albumin transfusions, is not getting better at all. So there it is said that you label him as SRNS, do the biopsy, shift over to second line immunosuppression so that he does not suffer too much in terms of like you're just sitting there labeling it as waiting for 6 weeks and then only you'll do a biopsy. So there you can
Yes.
just prepone and start at 4 weeks also.
Yes, sir. And the last point is that if a patient is of age of more than 12 years, presenting with the nephrotic syndrome like features, so Kedigo says directly go to renal biopsy, because these kids have high chances of having secondary nephrotic syndrome, but ISPN is quite on this point.
Fine. So basically, earlier, if you see the Indian guidelines, they should less than 1 year do the biopsy, more than 12 years do the biopsy. Like earlier, it was more than 10-year biopsy, then it became more than 12-year biopsy, and then it said, no, you start steroids. If the child is responding, you can just continue the same and need not do a biopsy. So why this KDCO has said this 12 years is because after 12 years or adolescent age group, there is a high chances of non-minimal change disease rather than saying secondary, a non-minimal change disease,
Yes.
which can be an FSGS, MSPGN, MPGN, C3GN. Okay, so these things are all become very common when it's post 12 years of age. That's why it is said like in case the age is more than 12 years, do a biopsy and go ahead and do. So, as the students who are joined in, it's better that you, in your exams you start quoting the KDCO 2026 guidelines, and also when you're talking about the Indian guideline, talk about ISPN's, yeah, IAP's 2021 guidelines. So there you have to be very specific. What are you trying to quote? Because at times, if your examiner has read the latest guidelines, so he'll be okay with what you are saying. If he has not read it and you start talking about the newer guidelines, he may say, no, no, you're talking wrong. So it's like better that you specify which guidelines are you quoting and what's new. So as residents, you should be aware of the newer guidelines, 2026 guidelines, which have come in.
Yes, sir.
Fine. So in case there are no more questions, we'll close it off because we already crossed the time. And thank you, Dr. Tanya and Dr. Shubham, for the inputs.
Thank you,
Thank
sir.
you so much, sir.
Thank you. Thank you.